A 61-year-old asymptomatic woman undergoes routine screening mammography. I am showing you the mammograms. Describe the findings.
Okay. The bilateral mammograms demonstrate a high-density, irregular mass in the upper inner quadrant of the right breast. The mass exhibits spiculate and microlobulated margins. No associated clustered microcalcifications or architectural distortion are identified. The left breast and left axilla appear completely normal. Given the spiculate margins and high density, this right breast mass is highly suspicious for a primary breast carcinoma, categorized as BI-RADS 5.
Based on your differential, what are the key mammographic signs that distinguish a benign spiculate lesion from a malignant one?
The differential diagnosis for a spiculate or stellate lesion includes primary breast carcinoma, a postsurgical scar, fat necrosis, and a radial scar. A postsurgical scar typically produces a spiculate density at the surgical site, but characteristically thins out or disappears on spot compression views. Fat necrosis can mimic cancer as a spiculate mass, but it typically develops central lipid density or peripheral rim calcification over time. A radial scar is a benign fibroelastotic lesion that presents with long, thin spicules and a central lucency, lacking a distinct dense central mass. In contrast, the most common mammographic sign of invasive breast cancer is a high-density central mass with ill-defined spiculate margins, representing tumor infiltration into the surrounding Cooper's ligaments.
Describe the next steps in evaluation and management for this suspicious mammographic mass.
The next step in evaluation is a targeted right breast ultrasound to further characterize the mass. On ultrasound, a malignant mass typically appears hypoechoic, irregular, taller than wide, and demonstrates posterior acoustic shadowing. Following ultrasound, an image-guided core needle biopsy must be performed to obtain histopathological tissue. If the mass happens to be occult on ultrasound, a stereotactic mammography-guided core biopsy or tomosynthesis-guided biopsy is indicated instead. Additionally, a bilateral breast MRI may be performed to evaluate the extent of disease and thoroughly screen for contralateral malignancies.
How would you manage this patient as a radiologist?
In that case, as a radiologist, I would recommend comparing these screening mammograms with prior films to evaluate for chronicity or recent changes. I would suggest performing the targeted right breast ultrasound and subsequent ultrasound-guided core needle biopsy of the suspicious mass. I would also recommend thoroughly evaluating the right axilla with ultrasound and performing a fine needle aspiration if any morphologically abnormal nodes are detected. Finally, I would document the findings, assign a BI-RADS 5 category, and refer the patient to the multidisciplinary breast care team for surgical oncology planning.